To walk, feel a breeze, or pull your hand from a hot stove, your brain exchanges millions of electrical signals with your body every second. All of that data travels through a single, incredibly vulnerable biological cable. This diagram shows the vertical boundaries of the spinal cord. It begins at the medulla, extending down to the conus medullaris, anchored by the filum terminale. Notice the cord bulges outward in two specific regions, the cervical enlargement and the lumbar enlargement. These extended sections exist because they house the massive number of nerve circuits required to operate our highly complex upper and lower limbs. Looking at a transverse slice, we see a physical split between the inner and outer areas. The inner, butterfly-shaped region is the gray matter, containing nerve cell bodies. The surrounding area is the white matter, carrying ascending and descending nerve tracts. The core rule of spinal topography is strict segregation. Different neurological functions do not mix. Motor signals travel in the ventral region, pain and temperature in the anterolateral zones, and fine touch and proprioception, your sense of body position, in the dorsal area. This strict geography means that clinical spinal cord syndromes are not random collections of symptoms. They are the deterministic result of specific geometric boundaries of tissue destruction. By mastering this topographical map, a clinician can logically deduce complex patient symptoms without relying on rote memorization. Zooming into the gray matter, the ventral horns house the motor neurons sending outgoing signals to your skeletal muscles. Conversely, the posterior dorsal horns act as receiving centers. Here, the substantia gelatinosa takes in incoming sensory signals for pain and temperature. Surrounding these processing centers is the white matter. Think of this as the vertical highway system, containing the ascending sensory tracts heading to the brain and descending motor tracts heading out to the muscles. To deduce clinical syndromes, we must understand the crossing rule. Fibers for fine touch and proprioception ascend on the exact same side, crossing high up in the medulla. Compare that to spinothalamic fibers carrying pain and temperature, which cross the midline immediately at that exact spinal segment before ascending. Finally, descending corticospinal motor tracts cross at the medulla and travel down the ipsilateral side to the muscles. Because these three vital pathways cross the midline at entirely different anatomical elevations, a single localized injury to the spinal cord will produce highly specific asymmetrical neurological deficits. Let's apply this map to a virtual lesion. Imagine a disease process that selectively destroys only the posterior third of the spinal cord. The entire dorsal column undergoes necrosis, while the anterior two-thirds remains completely active. We call this specific pattern of destruction posterior column syndrome, or tabes dorsalis, which is classically seen in patients with late-stage neurosyphilis. Based on the anatomical map, the resulting deficit is perfectly clear. The patient will experience a complete loss of vibration sense, body position awareness, and fine touch below the level of the lesion. However, their ability to feel pain and temperature, along with their motor control, remains perfectly intact. Those tracts sit outside the blast radius of the lesion. Now shift to the precise opposite geometry. An infarction, or tissue death due to lack of blood supply, wipes out the entire anterior two-thirds of the cord, sparing only those posterior columns. This structural failure is known as anterior spinal artery syndrome. The deficit is complex but logical. The patient suffers bilateral paralysis because the ventral horns are dead, and a bilateral loss of pain and temperature sensation because the spinothalamic tracts are destroyed. But because the dorsal columns are untouched, the patient maintains perfect vibration and proprioception. The anterior-posterior axis perfectly segregates fine touch from pain and motor control, making these two syndromes precise clinical mirror images of one another. Next, a fluid-filled cystic cavity, a syrinx, slowly expands outward from the center of the cord, physically crushing the immediate surrounding fibers. This insidious disease process is called Syringomyelia. Looking at a cross-section, we can see exactly what anatomical structure this expanding syrinx destroys first: the gray commissure, the tissue connecting the two halves of the gray matter. Recall the decassation rules. Only the lateral spinothalamic fibers, which carry pain and temperature signals, cross the midline at this exact spinal segment. The dorsal columns, carrying fine touch and proprioception, are located far in the posterior of the cord and remain completely untouched by this early central expansion. This creates a clinical phenomenon known as dissociated sensory loss. The patient loses pain and temperature sensation in a cape-like distribution over the shoulders and arms, but can perfectly feel fine touch. This highly specific cape-like loss of pain validates our mapping rule. Pain fibers cross the center immediately, while touch fibers avoid the center entirely. Now we apply the most catastrophic geometric lesion, a complete horizontal severing of the cord. All ascending and descending vertical pathways are instantly cut off. This is known as complete spinal sensory syndrome. The result is the total abolition of all motor control and all forms of sensation below the level of the lesion. Quite often, patients experience a narrow band of hyperesthesia, or extreme sensitivity, right at the upper margin of the damage. For the ultimate test of neuroanatomical logic, we cleanly slice through just one lateral half of the cord, leaving the other side completely intact. This precise left or right unilateral damage is called Brown-Séquard syndrome. On the ipsilateral, or same side as the injury, the patient loses motor control, fine touch, and vibration sense. The severed descending motor tracts and ascending dorsal columns are completely blocked. Motor and touch tracts don't cross until the brainstem, so severing them in the spine traps those signals on their originating side. However, the opposite side loses pain and temperature. Those signals originate on the healthy side, cross the midline immediately, and get trapped in the severed anterolateral tract of the damaged half. Brown-Séquard proves the brilliance of the cord's dual routing system. A single unilateral cut mathematically guarantees a perfectly split bilateral clinical deficit. Looking at these lesions side by side, we see distinct geometric boundaries: the healthy cord, posterior third, anterior 2/3, central expansion, complete cut, and hemisection. Clinical symptoms are merely functional shadows of this tissue damage. The physical shape dictates the syndrome. This framework gives clinicians immense diagnostic power in real time. If a patient presents with dissociated sensory loss, a clinician knows instantly to hunt for a central syrinx. If a patient presents with ipsilateral motor loss but contralateral pain loss, the clinician's mind immediately visualizes a hemisection of the cord. The spinal cord is not a black box of arbitrary, disjointed symptoms requiring thousands of flashcards to memorize. It is a rigorously engineered spatial map. By intimately knowing the anatomy, the pathology becomes flawlessly deductible.